Thank you all for joining today. We really appreciate people that registered and are participating. We had about 175 people register for this session. Just a few housekeeping items before we get started. The webinar is being recorded, and if you registered, you'll get a link to that recording after the session. And then once we get into the panelist Q&A, we'd ask that you use there's a Q&A function in Zoom that also has like an upvoting feature as well that will allow you to ask a question, and then if others similarly want that question answered, they can upvote it. I will say that we do have a bunch of questions that we received in advance, so we'll hope to get to some of those other questions as well, but we'll see how the time goes. And so my name's Jason Punt. I'm the Managing Director of Impact Consulting at Capitalize for Kids, or C4K for short. We are a not-for-profit consulting team focused on the community, child and youth mental health sector. We work with provider agencies to solve operational efficiency problems or implement new innovations. We have the privilege of working with agencies in the community, child and youth mental health sector, and I'll call out two because we have panelists from those agencies today. So projects like Strides Toronto, we're working with them to do an intensive services review and recommendations project in the Toronto region. And with Youthdale, we're working with them to design a formal step-up, step-down model for hospital to community. So that's just two examples of projects that C4K works on out of almost 60 projects that we've either completed or in the process of working on right now. Most recently, we've determined measurement-based care or feedback-informed treatment as a strategic priority for C4K for the benefit of our children and youth with mental health challenges. So we're in the process of developing a toolkit in collaboration with experts such as Dr. Karen Wang, who you'll hear from today, and in partnership with child and youth mental health agencies to help guide the implementation of MBC in the community sector. So at C4K, we have a singular objective is to see the child and youth mental health sector improve. And we'll work with agencies and vendors that share that goal. Also want to clarify that I get this question sometimes is like we're on here, part of this webinar with Greenspace, and we do not have a formal or exclusive partnership with Greenspace, but we'll gladly work with them or other vendors who share our objective of seeing the child and youth mental health sector move forward. So just before we get into the session, a quick background context for today's session. It grew out of a Children's Mental Health Ontario conference back in November 2023. Dr. Karen Wang and C4K submitted an abstract to run a workshop at that conference. And in parallel, Greenspace with Strides and Youthdale also submitted an abstract for that conference. And CMHO, because we were both talking about MBC, put those two presentations together. So when we were meeting to plan that session at CMHO, it quickly became clear that we had 5 speakers, actually 6, 5 speakers. And we knew that we would not have a lot of time to take questions at the conference. So we decided to hold a follow-up session to take more questions and sort of engage more with the audience from CMHO or others that want to learn more about MBC. So let me just share before we get into the session, just a definition to level set on what measurement-based care is. It's defined as the routine collection and use of client-reported progress measures throughout treatment to guide clinical decision-making. And here are the 4 C's of MBC, which are commonly referred to. First, that the data collection is consistent, so it's not just done once, pre and post. So we do talk to agencies who say, oh, we're doing measurement-based care, but they're only doing like the inter-RI chime, for example, and doing it pre and post. That is not measurement-based care. It's customized to the presenting issues and symptoms and the goals of the client. And the 2 on the right-hand side there, the client visibility is critical, that the assessments are visible to the client and discussed with the client so they understand what those measures are telling you. And then finally, it's collaborative so that the client and the clinician are using the data from measurement-based care assessments to guide treatment decision-making and different progress and different goals. And if I could ask each of our panelists to just do a short introduction and then maybe just give a little bit of background as to why you think measurement-based care is important and sort of why you're here today. What are the benefits that you see of measurement-based care? Maybe we'll start with Karen.
Sure, thank you, Jason. So I'm Karen Wang. I'm an adolescent inpatient psychiatrist at Sunnybrook Health Science Center. I'm also the co-chair of the Quality Improvement and Patient Safety Steering Committee. I'm currently spearheading MBC implementation on our inpatient unit, as well as leading a CPSO, so that's the College for Physicians and Surgeons of Ontario, CPSO Quality Improvement Project, whereby we're bringing on board physicians to learn how to implement measurement-based care in their own clinical practice. And the reason I feel so passionate about MBC is because we cannot improve things which we do not measure.
Thanks, Karen. And we'll go to Michael.
Good afternoon, everybody. I'm Michael Shreves. I'm the senior manager at Strides Toronto for our intensive services program. So everything from day treatment, live-in treatment, our party access, child welfare, intensive counseling. So we kind of embarked at Strides on this journey for MBC back in 2020. So it's been a slow implementation process for us. We'll go into that a little bit in a few minutes in terms of some of the details. But I think for me, one of the big things that really sold me on MBC was really the idea that, as Jason talked about, measurement-based care is not just about outcome measurement. It's really about clinical practice and tracking progress and experience throughout the client's journey. And we found that measurement-based care really does support that work and really does enhance the work. And from my perspective, MBC actually enhances outcome data because you have more opportunities to really engage from a client perspective in review and tracking of progress, really talking about impasses or area that they're struggling in, because the tools will give you that data, whether it's bi-weekly, month to month, how often ever you're using it. And it really helps the clinicians to engage in different conversations with their clients in terms of how is therapy going, how is the relationship going between caregiver and staff, as well as the client and staff, because we work with parents as well as the client in our programs. And I think from a clinician's perspective as well, what we have found at Strides is that it actually opens up different conversations. So our therapists have been really excited to use it because they've been able to see more data from MBC and more data from the assessment tools that they can then engage in different conversations than they would have normally had in terms of their session planning. So those are kind of the two kind of main areas I think that really sold it for me.
Thanks, Michael. Let's go to Jason.
Hi, everyone. I'm Jason Langer, the Senior Director of Quality and Evaluation at Youthdale. We started on a revamped quality improvement journey and strategic plan refresh a couple of years ago. A big part of that is transforming the delivery of services to evidence-based practices and improving data collection, use, and reporting in a way that informs decision-making and captures outcomes. These two objectives and key results are a big part of meeting our goals of clinical service, operational, and system excellence. We're entering the final phase of our implementation strategy in regards to evidence-informed tools. We started with Colocus and Locus, which helps us determine level of intensity of services required. We then moved on to OPOC, the Ontario Perceptions of Care tool, which measures the care experience in relation to current quality standards. And we started working with Greenspace in 2021 with a launch in 2022, which is a measurement-based platform that facilitates MBC, informs treatment planning, and tracks performance and outcomes at an individual program and agency level. And finally, we'll be turning our eye to the Inter-Eye Screener and assessment tool, which will be administered at set intervals throughout treatment. So we feel this will lead to consistent data throughout treatment, data-informed decision-making, enhanced assessment consistency and objectivity, improved services and new opportunities, ensuring appropriate and effective services. So we're working on transforming our services, moving from care to treatment, and providing the right service at the right time and place. So thank you all for coming, and I look forward to the discussion.
Thanks, Jason. And Simon. You're on mute, Simon.
I'm new at the Zoom thing.
Yeah, that's right. Your first time using Zoom, right? Yeah.
Hi, everybody. My name is Simon Weiss. I'm the president at Greenspace Health. We're an organization that was launched about 8 years ago out of St. Michael's Hospital. And our sole reason for launching and our kind of continued reason for existence is to bridge the gap between research and clinical practice when it comes to measurement-based care. We're fortunate to now be supporting more than 500 organizations with successful implementations of measurement-based care across Canada and the US. I'm very fortunate to be working, directly with 3 of the organizations on this conversation. And I think for us, what's really important is, we work with a wide range of organization types, levels of care, client populations. And I think what I'd hope to bring from that to this discussion today is a relatively unique perspective into, how organizations, of different shapes and colors are thinking about measurement-based care and how they approach not just implementation and getting to a successful point relative to their goals, but also, how they think about the value, what the reasons for investing in this are, and trying to bring as much of like the perspective of others to the conversation is what hopefully I can contribute. Why is measurement-based care important in my mind? Well, I've spent the last 8 years totally focused on this topic, not only as has been mentioned already, is there a real opportunity to have an impact, like a direct impact immediately for the next client you work with, but there's also a clear link to some of the system level challenges in this sector, whether that is, data on quality and effectiveness and impact to be able to advocate for the work that everybody on this call is contributing towards, or whether that's to, impact client or patient flow through services, or whether that's coordination of care. Like there's a long list of kind of system level challenges that this can contribute to. And I think for me, that's one of the main reasons why, I got into this and continue to be very excited about the potential.
Thanks, Simon. So again, just to level set on the questions that were submitted in, we sort of subdivide them into 3 major topic areas. First, implementation strategy. So we'll provide a bit of a framework for implementation, talk about barriers to implementation and some other things. Second category is in measurement tools and platforms. So we'll talk about, how to choose a tool and some questions about specific populations. And then we'll talk about client and family engagement. One question that came in sort of last week as well that maybe didn't fit perfectly, but we thought made a good sort of introductory question to tackle was, why has measurement standards in mental health care, why is it lagging other parts of the healthcare system? And if I could take a first crack at it, it's certainly not one specific reason. Things like funding. So at least in the community mental health sector, agencies are not funded to do measurement-based care. They're not funded to implement a measurement-based care system. Training also, MBC is not part of typical mental health practitioner education, though I know Karen is trying to change that at the University of Toronto, for example. And then also with digital infrastructure, often agencies don't have the digital infrastructure to implement measurement-based care. Simon can certainly speak to that later, but they have client information systems in the community, for example, but some of them don't have all the features and functions to do that. And then it sort of ties back to funding as well. And if you think about other sectors like oncology, for example, they have health systems, they have lab systems, pathology systems, and maybe more ways to objectively measure outcomes, such as like the size of a tumor, for example. Things are a little more complicated in the mental health world. And then another factor, I think, that's maybe making it difficult to, or why mental health is lagging, is just clinician attitudes and change management, where clinicians may have, been working 15, 20 years, and I have the experience to qualitatively understand what's going on with my clients or patients, and maybe not having the right mindset or the openness to look at other types of way to measure care through objective measurements. So that's just a few thoughts on that, but it's an interesting question to think about and study. So let's get into the first topic area, so on implementation strategy. So first is about, what does implementation look like? And we put a slide up here. So this is from the C4K implementation toolkit that we're working on with Karen and others. So this is just a high-level view of what an implementation could look like for an agency. So 5 phases. We kept it at a high level here, but we certainly have a lot more detail on what each of those phases looks like. So first, launching the project, getting a project team together, and then developing a vision and strategy for MBC for your organization, so that, you know, things about like, do you want to launch it across all programs or just some programs at first? And then, and what's your approach to developing what measures? Is it one measure across the organization? Is it going to be different measures for different types of programs? So lots of things that could be discussed at the visioning stage. Phase 2 is about choosing assessment tools, and we'll go through that in more detail in this webinar. Developing processes, so understanding what your current processes are, and then what a future state process could look like with the addition of MBC, because there will be, you know, it will change workflow. There are things that will have to change for that to be implemented. And then procurement of the digital infrastructure system that you'll use to implement MBC. Phase 3 is implementation planning, system configuration. So more detailed planning about how you're going to implement, what are the roles and responsibilities of the different people at your organization, and then working with the vendor to configure the system in the right way that will suit your workflow. This could also involve things like integration to a client information system or electronic health record system. Phase 4 being training and change management. So in the previous phase, you'd have developed a training plan and an approach to change management. And this is where that would be executed. And then phase 4 would be go live, but realizing that it's not over yet, where you want to do ongoing evaluation and improvement to the systems and constantly being in touch with the staff that's implementing. And that's sort of signified by that arrow at the bottom as well, where there'll be ongoing change management, probably starting very early on in phase 1 or 2, and then monitoring and process improvement evaluation. Maybe at this time, I'll turn over to you, Karen, just to give some of your experiences in MBC implementation and or tips and tricks.
Sure. Thanks, Jason. So maybe just to provide some context, I currently work in a sort of medium-sized department of psychiatry with around 50 physicians and close to 200 staff overall, if we're including all of the allied health and nursing staff as well. And when we started on this sort of MBC implementation project, we initially gathered a group of MBC champions and supporters. So physicians and also our chief, who was very supportive of looking at how we could implement measurement-based care across our inpatient and outpatient contexts. And we had a very strong vision that we wanted to start somewhere where people felt comfortable. So we recognized very early on that not every clinician would be comfortable fully switching over to using scales or symptom sort of measurements for every clinical encounter, but at least from starting with a consultation, that could be maybe the first sort of position of change. And we quickly then moved to deciding on what that scale would be. And for us, we landed on a depression measure because we felt that this was the most common presentation to our Department of Psychiatry, whether for inpatients or outpatients. It was easy to administer. There were many clinicians that had already been using a depression symptom rating scale. And so it was a matter of trying to consolidate and sort of moving away from everyone having their own unique favorite measure to maybe a maximum number of 3, and that they could have some choice and agency in choosing amongst the 3 that we were offering. As Jason also talked about, there is an iterative process, and all of this took, several months to work through, and there were many discussions, both informally and formally, before we actually even began the procurement process. I think it's very helpful to have a framework overall, and we sort of rely heavily on the IHI framework, the PDSA cycles of plan, do, study, and act. So taking feedback on an ongoing basis from our providers as well as from our patients to then look at improving processes. So in terms of the actual implementation, the very first group of individuals that we trained to utilize a digital platform to capture measurement were actually our administrative assistants. They were going to be the ones that would be calling the patients and helping them to register on Greenspace. So we do use Greenspace currently. And we felt it was very important that they were on board and understood how to integrate this into their workflow, and also how to assist physicians then in looking up their measures if they were struggling to do so. So moving along and then working with the actual physicians and various allied health, we've now been able to implement this across the board. And over the last year, we've been able to accumulate close to 3,500 patients who have registered on Greenspace. We've just sort of touched the 20,000 sort of data point level. And so we're starting to look at aggregate data instead of just identifying each individual patient outcome and sort of thinking through the one-to-one relationship between the physician and the client in terms of how to improve that. So it's very exciting. We are moving into a more mature phase of implementation, but it's definitely been a long journey, but lots to learn along the way.
Jason, any thoughts on implementation at Youthdale?
Yes, we started with focus groups and workshops. After accreditation in 2018, we recognized that the use of evidence-informed tools throughout our practice was a growth opportunity. In meeting with clients and caregivers, we heard loud and clear from them that they would like to see some evidence that the treatment is working or of their accomplishments. So after that, we started to build a plan through extensive research and literature reviews and started engaging with Greenspace and to develop our plan further. I think it was very important for us to first get buy-in from all levels of the organization to tell them about the why and the so what and why it's important. So we went on a big tour. We met with every team. We met with doctors, psychology, social workers, CYCs, nurses, and leadership to gather their input. We also went to town halls and leadership meetings to show our materials and our plans for evidence-informed tools and to gather feedback. At the same time, we gathered input from all of these teams about what kind of skills they would like to see used and what are some of the skills that they're already using. So we developed specific reference guides, a clear instruction manual for each program, and compliance trackers. We have checks and balances from our quality department that measure compliance rates so we could stay on top of it. We continue to gather feedback. We're fortunate to have a former parent on our board and a client advisor to the board, so we're as well, and they were also part of our strategic planning committee. So we're continually gathering feedback on our practices. And the use of evidence-informed tools is informing treatment planning at the agency and is regularly presented to all levels of the organization. So often we've heard that people don't understand why they're collecting data, they don't know what happens to it, and they don't see the results. So we're really communicating the results and communicating to funders and community partners as well.
Right. Mike, anything on your end, anything different?
Yeah, we at Strides took a little bit of a slower approach. We did a pilot model, actually. So we also engaged with Greenspace in terms of our platform and our supportive, guide in terms of this process. And so we worked really closely with Greenspace to talk about the programs that we would start piloting in. So we piloted it in our intensive services programs, our day treatment classrooms, and our live-in treatment program. And we did it at both age ranges from latency, kind of 6 to 12 and then 12 to 18. And the way we approached implementation was we really wanted user acceptance and user testing. So we really gave the therapists free rein in the first few months just to test out the tools, see what works, see what you like. Greenspace has a plethora of database of tools. And so we just really encouraged our therapists to go through, start looking through the different cycles of what tools might be helpful in terms of the work that they're doing. And we took a symptomology approach. And so what we did is, as opposed to choosing 2 or 3 different tools, we landed on tools by symptomology. So we all landed on, if you're treating depression and depression symptoms, we would all use the PHQ-9, and for the latency programs, they would use the RCADs because it's for younger kids. And so we kind of took that approach where we gave therapists a lot of choice over the tools that they used so that they can really use a tool that is relevant to them in their clinical practice. So if someone's treating OCD, they can use a tool that's related to OCD. If they're treating anxiety, they can choose a tool that's related to social anxiety, generalized anxiety. So we kind of went that route, which we found our therapists really found useful in that the tools are really relevant to their work across all clients. Because one of the beautiful things about Greenspace is it converts the actual assessment scores to improvement scores. And so from an agency perspective, we can still track improvement even if two therapists are using different tools to treat different kind of symptoms in terms of the things that they're working at. So that's kind of the approach that we took at Strides, really to let it be clinician driven in terms of engagement so that they have a buy-in in terms of this actually benefits my work and my client's work kind of in the moment.
Great. Thanks, Mike. Maybe just a quick follow on to the panel, just about like how long do you think, obviously every agency can be different, but, as far as time frame from when you start the MBC project to implementation, what do you think you're looking at time-wise?
At Youthdale, it was a 6-month process, which included training for every team. So yeah.
Okay. Karen, Mike?
We at Strides took about 1.5 years. And so we did a pilot project for about 1 year where it was just really testing. And then this past summer, we actually broadened it out to all of our mental health departments. So every mental health program is now doing Greenspace. And so that whole process of training different teams and bringing teams in to choose their own tools by program took us about 1.5 years. And we're still at the infancy stage of now evaluating, is it working? And right, like the compliance issues, all those kinds of things. So it's an ongoing process for us.
Okay. Yeah, I think as far as that framework that we put up earlier, I think it depends on the agency, but I think what we're seeing is that to get through all that and do your normal clinical work, to us, it looks like about 1 year. So I think you guys are 6 months, 1.5 years. So it's almost averaging out to 1 year. So next topic was just in this implementation topic area was about getting staff on board and addressing barriers such as staff capacity, workload. So it's essentially a change management question. And maybe Karen, we'll start with you, what your thoughts are on that.
Sure. Did you want to also put up the slide, Jason? The barriers?
You mean like this wasn't planned in advance? No. There you go.
So first of all, I have to say our implementation path has taken a lot longer than 6 months to 1 year, primarily because the procurement phase took almost 2 years. So that was primarily due to just, some difficulties and hurdles with privacy and legal. But otherwise, once we were able to procure the digital, platform, then it was within about 1 year. I think one of the challenges that we've faced early on is actually clinicians' sort of attitudes and beliefs about measurement-based care. And so, I've listed out a couple of different strategies that people might want to think about as they're trying to overcome what I would say MBC resistance. The first thing was that we spent considerable time just reviewing the evidence. And for several clinicians, they really needed to see the data. How was this going to impact them personally? Was there solid sort of systematic reviews, other studies, RCTs that demonstrated that MBC was a superior approach compared to their sort of clinical gestalt? And again, we utilize things like grand rounds, other educational forums, bringing in other MBC experts to really help clinicians identify their own underlying assumptions. Sometimes people think that MBC is going to take a whole lot more time. Again, we started to debunk some of those myths. Many of these scales can be easily completed within 3 to 5 minutes, and especially if they're being administered in a routine fashion, clients should be able to complete them fairly quickly once they're accustomed to how to fill out the scale. We also started to reframe the reason for measurement-based care. Sometimes there can be this fear that measurement-based care only exists because it's going to be utilized in a negative way for performance evaluation, and that eventually everyone is only going to be compensated if they're showing some sort of demonstrable improvement for their patients' symptom scores. And so trying to reframe the reason as actually, no, we're doing this because we care about patient outcomes. And it's very difficult to actually note what to improve, what areas to target, what symptoms to highlight if you don't have some sort of objective measure that you can be tracking on a consistent basis. Certainly patients have told us this, even on the inpatient unit, that it really is very helpful for them to have a dashboard to see how they're faring. It gives them hope. It gives their caregivers, their parents hope as well that they are improving based on the treatment. And if the trajectory is not as planned, then it opens up a dialogue with the clinician. Where do we need to make adjustments? Do we need to intensify treatment or change to a completely different kind of a treatment approach? The third sort of strategy is what I call reassuring the clinician. So where I work at Sunnybrook, my office is actually in the middle of the hallway, right next to the only set of washrooms. So every clinician seems to have to walk by my office, and I keep my door open pretty much at all times whenever I'm in. And more than not, people have often popped into my office, closed the door, and quietly whispered that the reason why they were so terrified of measurement-based care is that they're afraid that somehow they won't be able to do it. They won't know how to utilize this approach. They don't know how to talk to the client. They don't know how to even perhaps log in and register on Greenspace. So a lot of my informal coffee chats, sort of private conversations, is reassuring the clinician that that's why I exist, is to really support them, and that it's going to be a journey together, that nobody has all of the perfect answers to MBC implementation, and that we're going through this as a quality improvement project. So whatever they're discovering, please bring it back to the larger group so that we can all learn together. The last piece is around rewarding implementation efforts. So what we've been able to do at Sunnybrook in order to really push the needle in terms of getting clinicians to utilize these skills is we've linked it up with another initiative that's been offered through the CPSO. And again, this may not apply to all of your institutions, but this was a very tangible benefit. If physicians joined our CPSO MBC project, in essence, they would not have to undergo a pure auditing process through the college, which happens every 5 years. They would be exempt from that. And I can't tell you how many physicians were so relieved that they would be able to sort of latch into our existing infrastructure, which would support them through this 1-year long process, instead of having to then be audited and sort of go through this other sort of separate process by someone else that they were not familiar with. So I'll leave it at that, but those are the 4 R's that we found were helpful for overcoming some of the barriers and the attitudinal sort of concerns around MBC.
Thanks, Karen. So key finding there is change champion, office by the bathroom. I guess that was one that stood out for me. That's great. So the last topic area in implementation was about why and how should agencies pursue MBC without government sector direction or funding. So we alluded to that in the first question too, about there doesn't seem to be funder sort of direction on MBC right now. So Mike, why don't you take a first crack at that one?
Sounds good. I think one of the big kind of distinctions, and I think Jason and Karen spoke to it very eloquently, is the difference between outcome data and measurement-based data. And I know funders in the ministry are looking for outcome data, pre, post, what is the impact that this work or this approach, this model had on care with this client. And what I've found as to the biggest why is measurement-based care and measurement-based assessment actually informs the outcome. It actually helps clinicians to see how they are improving with their clients, how they are working, what's working and what's not on a very structured timeline. And so I think that for me is the biggest why. Because in theory, measurement-based care is not about a platform. So yes, like I think all 3 of us in this discussion used Greenspace. It's a beautiful platform, but in theory, it does not require a platform. It's the concept or the philosophy of checking in with clients on consistent bases, not just about their qualitative feedback, but quantitative feedback of how are they actually doing in their clinical progress when it comes to their symptoms. And so one of the things that I love about measurement-based care is there's lots of free tools out there. Yes, there are tools that require license, but there are free tools out there that anybody can use. I mean, we're using like the PHQ-9, the GAD-7, things like that they're really 6, 7, 9 questions. They're not long. They're not something that's onerous for clients to do. And so any clinician can pick up a tool and just say, hey, every month I'm going to check in with you about your depression. I'm going to check in with you about your anxiety or your OCD symptoms or trauma symptoms. And it really provides a feedback loop to the clinician to these are the areas that the client is struggling with. These are the areas that they are actually making improvement in on a very granular level, because one of the things I love about Greenspace is it actually itemizes every single assessment score we do long-term therapy for a year. So you can, in theory, look from beginning to end, all their course of treatment, every single line of what they've scored, so you can start to assess patterns really quickly. And that is invaluable to a therapist, where a therapist can look and say, hey, for the last month, they've been scoring at a high level in suicidality, in feeling hopeless, in not getting enough sleep. And that's what you can actually then go back to your client and target. The second why for measurement-based care, even without direction, is, it really provides client feedback to the therapeutic relationship. If you use therapeutic alliance tools, it really helps to strengthen the clinical relationship between client and their therapist or their worker, so that there's a constant, again, feedback loop about how are we doing in this relationship. There's lots of tools that we use that assess therapist bond versus therapist alignment on goals. So we have found a lot of the times that, clients, especially the compliant ones, don't really want to tell their therapist that I'm actually not aligned with you, or I actually don't agree with our goals, but they're being compliant, and some are resistant and actually can speak up. But we find a lot of the times that they will fill out the tool and say, actually, I don't agree with my therapist on their goals. And that's a great opportunity to actually check in every month or every 2 weeks to say, hey, you said you didn't align on this goal. How can we fix that? Versus the subjective approach where we go through assumptions and maybe 3 months later we figure out that they weren't aligned on their goals, and that actually deteriorates outcomes. So I find that's the biggest why for me. The how is really, as I spoke to before, yes, the software is beautiful, it works, but we understand that funding is also an issue with that. But in theory, there are things that you can do to apply measurement-based care even without funding, even just whether it's a paper and pencil model of just a therapist bringing tools into their session to be able to assess regularly and get quantitative feedback that they can track over time, because we have found that actually increases outcomes. It actually also increases therapist and client engagement, because both the therapist and the client can see their own progress in real time quantitatively. And we've had a number of clients come back and say, I didn't think I was improving, but in 6 months, I went from a 24 to a 4 on my PHQ-9 for depression. And they didn't really realize how much progress they had made, but their scores tell a different story, which then improves motivation in therapy. I can talk about this for hours, but I'll leave it there.
No, appreciate that, Mike. Oh, that's great. And Simon, maybe we go to you. Just you probably have a unique perspective. Like, we're the 3 clinicians here are in Ontario, so they have an Ontario government to deal with. You across Canada, North America, even other parts of the world, dealing with other sort of governments. Like, do you have a unique perspective here?
Yeah, I think maybe the first thing I'd say is Mike did a perfect job of laying out one of the key reasons why an organization would choose to invest in measurement-based care. And often that's the initial impetus for thinking about this, right? It's the clinical value and the impact on outcomes, right? Thinking about the care you're delivering to clients and families. I think across geographies, we seem to have lost Jason for a second. Across geographies, there are also some elements that are very consistent around why a team would choose to invest, and some of them actually correlate to a direct return on investment and value back to the organization. The quick ones I'd list off is impact on client engagement, and more tangibly impact on dropouts, no-shows, cancellations from care, and what that means for an organization. I think it's the real-time data and the ability to have clear oversight over a client population for supervision and care managers to be more actionable when working with clinicians and through care consults. I think there's then a whole element around data. So the actual aggregate data to be able to understand quality, impact, et cetera, for internal evaluation, but then also the ability to use that data externally. So this is where things start to look different across geographies. When you think about how data can be used externally, when you're talking about the quality of your services and the impact you're having. So for partners in Ontario in the child and youth sector, one of the areas we talk a lot about with teams is being able to use this to impact your funding. Whether you're bringing in funding from donations and being able to tell your story better, or it's through grants and being able to write better grant applications or demonstrate quality. Whereas in the US, we're seeing a really big shift towards value-based care. And because it's not a single payer system, although I think in child and youth mental health sector, it's also not really a single payer system. But with insurance companies in the US, there's a shift away from fee for service to value-based care. And so measurement-based care has really become central to that conversation as the way for providers to demonstrate the impact of their work on outcomes. And maybe the link that we're starting to get to there, we've seen it in the UK, now we're seeing it in the US, it's going to come to Canada, but drawing a line between MBC data, so impact on client outcomes, to cost of care. So actually being able to tell the story that like the impact we're having is generating meaningful reduction in healthcare costs, both mental health, substance use, physical healthcare costs across the sector when we deliver positive outcomes in the settings that we're all working. So that's the story that's starting to evolve in this sector. And I think when we think about, maybe this is a bit broader than like, why do this if it's not required yet or funded yet from government? But this is the direction. And I think for organizations that are investing in it, there's sometimes a belief in that, that future state. And other times it's because, it's for a clinical purpose for a specific program where they want to improve quality.
Yeah. Thanks, Simon. And let's hope that, despite that funders do see the value and start funding that specifically for the good of our children, youth, and families. So just interest of time, let's switch gears and talk about the next sort of area, measurement tools and platforms. The question is about how to select the appropriate measurement tools, length, language, etc. And maybe we'll go to you, Jason, to start talking about that.
Yeah, first we rolled up 10 years worth of data of presenting issues of all our clients. We do work in a highly acute population, serving level 4 and 5 clients. We realized that over 90% of our clients were coming in with anxiety and depression symptoms. And in consultation with all our teams in psychiatry, we decided on a standardized approach with flexibility unique to the client's needs. So we standardized the administration of the PHQ-9 for depression, the GAD-7 for anxiety, the BRY for therapeutic alliance, and the Columbia Suicide Severity Rating Scale. And we have set intervals for each of those in each of the programs. There's a whole series of other tools available on Greenspace. We've reviewed all of those and shared those with teams, and we leave it up to the clinical teams to administer other tools unique to those client needs, and there's stacks of tools, ADHD, PTSD, eating disorder, borderline personality, everything. So we feel like we've standardized some that are important to all of us, and we've certainly left some flexibility with the team. So we're pairing quantitative data with qualitative data and clinical judgment. So we met with reps from all departments. We met with clients and caregivers before launch. We gathered all their feedback. We came to an agreement, and that's how we came to our decision. We also researched all of those tools. We wanted tools that were easy to use, short, and tools that the clients can understand.
Right. Thanks, Jason. Karen, could you maybe talk a bit about the factors that you used in selecting tools and sort of best practices that you've seen across the child and youth mental health sector?
Sure. I mean, Jason has alluded to some of them already. So obviously there are a number of different considerations. You really want to be thoughtful about what the actual tool is measuring and what's your sort of key focus area. Some tools are primarily sort of symptom based or symptom focused. Other tools are focused on functioning, like global functioning, or perhaps it's about the therapeutic alliance. If you look at the tools, some of them have been constructed whereby they're assessing the intensity of symptoms versus the frequency of symptoms. So for each of the clinicians in your various clinics, you want to sort of help them work through this thought process. What's really important and key? How frequently are they also going to be using these tools? Is the intention here primarily for screening purposes? There are also some rating scales that are quite lengthy and they're used primarily for diagnostic reasons or more for like monitoring. Jason, you had talked about doing the research behind each of these scales to understand their validity and reliability scores to determine, how well they can detect change and improvement. Because I work with teens, they're definitely not going to answer a 60-item questionnaire. They like things that are very brief. And so we've also had to settle on tools as well that were usually within like 7 to 10 questions. So either it's going to be like an anxiety scale like GAD-7, or it could also be the PHQ-9. We also do have lengthier anxiety symptom rating scales like SCARED for younger kids, which I noticed in the chat box, somebody had asked about parents' role. So because the teenagers that we see are 14 and up, as long as they understand how measurement-based care works, how the platform works, they can actually sign on using the account fully for themselves. And we do encourage the parents to help assist the child or teenager to fill out the scale if they're struggling with some of the questions. Language and cultural bias, that's also something that a lot of clinicians are worried about. Will they understand, will their patients understand how this scale is utilized because of the language, or if there's like a cultural framework in which it was sort of composed. So again, thinking about those factors. And then there's the self-clinician or expert administration. Can this scale be used primarily just by the patient, or is it supposed to be used by the physician? Some scales, so not necessarily the ones that are on Greenspace, may require additional training. So you actually have to get certification to administer the scale. So these are all just various factors for you to think about and work through. And again, it does take time in consultation with your working group. I think it's helpful to kind of like identify what might be the most commonly used scales first, and then sort of think through how might those be implemented, and then start branching out. One thing I should mention is that when we first launched, we made it very clear that we did not want clinicians using more than 2 to 3 scales for their outpatient consultations. We did not want clients or patients to be inundated. And we also didn't want clinicians to just be sending out a lot of scales without actually checking the information. So we veered towards sort of fewer scales, but actually having more consistency.
Thanks, Karen. Mike, there's a question too about specific populations, so very young children, culturally specific programs, caregivers, et cetera. Could you maybe talk a little bit about that?
Yes. So at Strides, as I said, we piloted the project across the age continuum in all of our intensive services. So we didn't initially go as early as early years of life. Our day treatment program started in grade 1, so from like 6 all the way to 18. And the way we approached it was we really separated by the scale. So as we talked about before, we did like more of a symptomology based approach in terms of our thinking of how to implement Greenspace. And so we just had therapists and our managers land on, okay, for depression, if you're under 12, well, there's the RCADS, which is it's a longer tool. It's about 17 questions, I think. But we felt like once a month they can fill that out, and they've been doing it. So it measures both anxiety and depression. Whereas at the adolescent side, we would choose tools that were geared and validified with kind of that age population in range. So like the GAD-7, the PHQ-9, I think are all like 12, 13 plus tools. And so that's kind of how we really looked at age specific tools. And so when we launched in our mental health department, we even had our infant mental health team start to think about tools. And I know Karen mentioned one, the SCARED tool, which is the screen for child anxiety related emotional disorders. And so they had already been using that tool. So we're like, great, let's put that into Greenspace. And thankfully, Greenspace already had it. So we've really looked at teams and specific populations in terms of what they're already using and can we incorporate that into Greenspace. So they had a need for like really assessing emotional distress. And so we found a tool called the Pediatric Emotional Distress Scale, which is the PEDS. And it's as early as 2 years old, and it's really geared towards parents. We found a parenting daily hassles questionnaire that goes as early as like 3 years old. So we've really Greenspace has a lot of tools, and even the tools that they don't have, we've been working with Greenspace to say, hey, we're thinking about this tool. Can you help us with the licensing, or is there a license required? Kind of to Karen's point, some require licensing and training. And so as you get more mature, you can start to look at specific tools that you really want to implement. We started with the tools that are available to us, that are widely researched, that are widely available and used, and that's kind of how we started. In terms of our older population, to Karen's point, we started really venturing into, as we talked about, symptomology-based kind of assessment. And so there are tools that are a bit longer. And so especially with our trauma clients, we really said, we really need to track trauma and trauma symptoms. However, a lot of those scales are 30, 40, plus questions per assessment. And that was actually one of the challenges that we had, is we had to figure out how do we keep engagement while still wanting to track really important population specific symptoms. And so we just really played with the frequency. So instead of doing it every 2 weeks, we do it once a month, which we've been able to improve compliance with that because a client recognizes how beneficial it is and they're not filling it out every week or two. And so that's kind of how we've negotiated that. We used one tool, which is not really for monitoring. We use it more as an intake tool. So there's the ACE-Q. We found that from a specific cultural and, thinking about cultural factors with trauma, the revised adverse childhood events questionnaire does start to ask questions about immigration, refugeeship, having a parent that was deported, a parent in prison, looking at things like bullying and identity and sexual identity. And so there's really specific questions that really go from a broader, more cultural lens when it comes to trauma, whereas the old ACE questionnaire was very specific, very westernized. And so we've started to adopt that. We're still in our infancy in terms of using that. It's not really a monitoring symptomology. It's more an assessment tool that we use at the beginning when they first come into our program. So again, lots to talk about, but I'll leave it there.
Forever, I know, Mike. Yeah. Yeah. Simon, I know just, with Greenspace and all the tools you have loaded up in there. Any thoughts on specific populations? You'll get it eventually.
Maybe, yeah. Maybe what's most helpful for this conversation, I'll just add quickly. I think you're getting a pretty clear sense of the approach that, Sunnybrook and Youthdale and Strides took. And also hopefully what's coming across and what I really like to hear is the level of iteration. And I think it can often feel like a barrier or hurdle for organizations that we've got to go so deep on research and we have to become experts on all of the potential assessment tools out there before even getting started. And I think what I'm hearing in this conversation is there's actually a lot of value in starting in one place and allowing that to evolve and change based off of clinician feedback, client feedback, family feedback, and letting it be I think themes we're hearing all the way throughout are iterative approach to implementation, engaging clinicians and families throughout. I think these are really strong values that can kind of apply to almost any of the questions we're going through.
Right. So just finally in this section, just a question that actually C4K gets quite often is what platforms are out there to implement MBC? I will say that, from our interactions we've had with agencies and the literature, the challenging part of MBC is not the digital platform, it's the change management, the getting the clinicians on board. I will say that in our, so Greenspace has obviously had a lot of attention here, and they're, I think, certainly the leader in Canada. Some of the other systems that we've seen, there's one called My Outcomes that's been implemented in an agency that we know of. And another one, I think that company's out of BC. And then another one called Voxy that was developed out of the Hospital for Sick Children that is starting to be implemented. But I'll just shift gears out of that. Certainly you can contact me offline as well about that. But Simon, another question that came up was about what are the options for integration? Maybe just talk really quickly about integration with Greenspace. Is that an important aspect of implementing MBC?
Yeah, I think it's one of the aspects. Obviously integration involves, for our team, it involves Greenspace and an EHR or client information system, whatever term we're using. And I'd say different systems are at different phases of their level of interoperability. I think we've found in some sectors in the US they're a little further ahead and integration's easier. In the child and youth sector in Ontario, we've completed an integration with EMH, one coming up with Vital Hub's Treat system. At the end of the day, it's helpful, but I think as Jason mentioned, there's other, we're talking through a lot of them, but there's other kind of challenges and hurdles to overcome with implementation. And, part of this is technology, part of this is implementation. Within that technology sphere, integration can support workflows, but it's also not the only way to make this efficient and effective for teams. I would say the best way to think about this holistically in terms of getting clinician buy-in is you've got this scale of clinician value versus clinician effort, and being able to add integration, which is ideal, would be able to reduce clinician effort. But we're still always playing with that scale of how do we implement this in a way that's driving more value for clinicians and limiting their effort. And that's how you're going to be able to build that buy-in and a successful process.
Thanks, Simon. All right, let's shift into the last topic area. We've got about 5 minutes left. I think we can do it. So client and family engagement. So how do we know if MBC is working in client care? Mike, we'll give you first shot at that.
So I think one of the most important things, as we talked about, is the fact that measurement-based care takes data throughout treatment. So it's, we're used to in our system, especially in like child and adolescent mental health, it's like, okay, you do your plan of care every 5 months, you do your check-ins. They're formalized process, but in between, there's really no formal process. And what I find with MBC, how you know it's working is if you're checking with a client every 2 weeks, let's say, or every month, you're getting regular data points in that snapshot period of time of how well they're doing. And it gives you opportunities every check-in point to actually amend your treatment plan. And so if you see a client is struggling with suicidality, you know to target that next session even before they come into your door. Likewise, it shows areas of impasse. If you're seeing where there's areas of stuckness with the client, you can address that because you're seeing it in the scores. And you can also see the areas of progress. So if you know in the last 3 assessments, you're seeing that clients improving in their sleep, they're improving on their thoughts of compulsions when it comes to OCD. It's great opportunities to be able to check in with the client and you see the data in real time. And it also gives the client the opportunity to see the data in real time. So we know it's working by the client's own report and their own feedback through the assessment tool. And from the Therapeutic Alliance tool, it's the same kind of principle that we know it's working when we see those scores of improvement increase. So when you see that the alliance with your therapist is getting better because you're constantly checking in about that, that also leads to better therapy. When a client and therapist are aligned, we know the research says that about like 60 to 80% of therapy progress is the therapeutic relationship. And so why should we not assess that? And so it's really important to assess that relationship. And when you see the relationship maintain at a high level, you often see the outcomes actually improve.
Thanks, Mike. And the next question was about aggregate outcomes. I think Simon spoke to that a little bit earlier. So why don't we just shift to the last question about how do you encourage client-family engagement and avoid compliance fatigue? Jason, why don't you give that a shot first?
Yeah, I think MBC really allows for a better engagement with youth and caregivers. So to avoid compliance fatigue, it's just about education. It's about sharing the results with them in a timely manner. And we explained Greenspace before it's administered to all of our clients and offer the opportunities. So it's voluntary, although we do have pretty firm expectations in our programs. And we haven't really, it's been well received. We haven't really faced any issues with compliance fatigue amongst our clients who are living with us for a period of time and they have the time to complete these very short assessments.
Great. Karen, your thoughts?
So I think it's about reframing how we think about measurement. Certainly, patients are not going to appreciate us handing out these tools routinely if we're not actually using that data to inform their care. So I have not found that patients are resistant to completing the scales if it provides meaningful feedback and they can see that we value the time and energy that they've put into completing the scales as well. In fact, in my private practice, I don't see a patient unless they've completed the scales, because in essence, the sort of metaphor that I've given to them is, like I would never go into a vehicle without having a functioning speedometer or odometer. I don't know where I'm going. I'll be driving blind. So I want them to get the sense that measurement is actually integral to how our therapeutic encounter is going to work. And it's just part of the structure of how I frame our sessions. And in fact, the feedback that we have gotten at Sunnybrook is that this contributes to a sense that they're being cared for, that it's professional, and that it helps them understand more about their own disorder and how to work on improving and sort of reaching that state of recovery.
Great, Mike, we'll give you the final 20 seconds. Do you have any thoughts on that?
Yeah, I think, I mean, Karen just said it eloquently, Jason just said it eloquently. I think really what we've noticed is one thing that was a challenge was access to technology, because we're using a technology-based platform. And so it's really just making allocations for if your clients can't access internet or phone or text, really just doing it in session with them. I think that's been the best opportunity. We did it in live-in treatment where they live with us, kind of similar to Jason, or in day treatment where they're with us 6 hours a day. It's kind of, you have opportunities to say, okay, you didn't fill out your Greenspace, let's do it together, and it really just provides a means for them to fill out where there's no barriers. I think that's been one of the issues with compliance. And I think the frequency with long-term therapy, because some of our clients are there for 2 years, every 2 weeks became too much for them. And so we just we played around with the frequency for some of the assessments. And so we moved it to kind of every month. So it just meant it's a little bit less on the check-in side, but in a 12-month course of treatment, we're still doing 12 check-ins. So we felt that was enough. But for shorter periods of therapy, we're still kind of doing that 2-3 week window, depending on the time. So those are the two barriers I think that we've faced.
Right. All right. Thanks, Mike. That's the last word. I really appreciate the panelists' time and all of your time for joining. We got the email addresses from all the panelists and myself up on the screen. I want to thank Britt and Tanya from Greenspace who've been helping in the background, as well as Christine from C4K. There'll be a short survey coming out through Zoom, just a very few questions just to give a bit of feedback on the session. Feel free to contact any of us and myself, especially if you have any questions about implementation of measurement-based care in the community sector. But I want to thank you all for joining, and I'm sure we'll talk to you again soon.